Thank you, Suresh. I'm going to walk around, so I make the cameraman's job a little more difficult at times. Like Suresh said, we wanted to start off with 10 things, but then we thought if we told you all 10 things, you'd take our jobs away. So we'll probably be doing this down to about number 6 or so. How does this advance?
Yeah, should move.
There we go. Okay, so for the first response, I guess before we, just by a show of hands, how many people in this room admit to having children? Okay, so about a half. Okay, so the first question is, does anesthesia make you stupid? And so number 1 would be yes. And number 2 would be no. So we can try that on the audience responses. So this tends to be one of the more frequently asked questions of parents coming to the operating room. So roughly 24% of you believe that there is an issue with regards to neurotoxicity and anesthetic-related agents. Okay, so a couple of things. I just, by way of disclosure, I do have grants. I have grant support from Janssen, Hospira. I've done work as a consultant for Janssen, and also have done grant support from Cumberland. I guess I should disclose that I have been involved in clinical trials, both in the hospital, and also I was a college student of the 70s, so I believe I may have participated either knowingly or unknowingly in some clinical trials. So the issue of neurotoxicity. Anesthetic agents in general are thought to work by one of 2 mechanisms, either by inhibiting or by stimulating GABA receptors or by inhibiting the excitation and depressing NMDA receptors. What we do know is that if you think about it, there must be a period of vulnerability for all of this, at least in animal studies. It's been demonstrated. We know that as a normal part of neurodevelopment, there's apoptosis that occurs, there's neurogenesis that occurs, and once cells have migrated, made synapses contact with each other, we know that there are changes that go on in the dendritic spine that allow either apoptosis to occur or not occur, so that there are constant changes in neurodevelopment that are happening. And it wouldn't be surprising if anesthetic agents or any other agents for that matter that might interfere in that process might have a detrimental effect on the outcome. I'm not sure where the... So what we do know, at least in rodent models, is that, in fact, depending on what age you expose animals to, the incidence of neurotoxicity changes, and it's different parts of the brain that are affected. In the rat model, around 7 days of after 7 days after birth seems to be the peak where both behavioral and histological changes will occur with neurodevelopment. What we know on a clinical basis is the following, and that is there have been a number of studies that have been done that both have positive findings and negative findings. And what I want to do is just take the next couple of minutes to go over this. I want to just by preference, before getting into these, is say that the animal models are very clear in terms of demonstrating that there is a neurotoxic effect. But most people here want to know what is the clinical relevance of these particular animal models. And so if we start to look at some of these studies, maybe, okay, whoops. If we start to look at some of these studies, I just want to go through them. And one of them is the Block study from Iowa. The Block study, how many people here are old enough to remember having taken the Iowa test scores in their grade school or elementary school? It was a relatively young audience. So these Iowa test scores were given every year to grade students throughout the United States. So there's a tremendous amass of data on all of this. And in the particular block study, what they did is they looked at kids that had surgery either under a year of age, either for pyloric stenosis, inguinal hernia repair, or circumcision. And what they noted in this particular study was that you would expect a normal distribution of scores to occur. And what they noticed is that the kids who had surgery under a year of age for these three particular operations, what they in fact found, there was a higher percentage of kids who scored in the less than 5th percentile for this. So in other words, if you take the general population, you would expect 5% of the kids in a general population to be at the bottom. That's a normal distribution. If you now looked at kids who had surgery, what they found was that 14% of those kids fell into that curve of the lowest 5% scoring kids. So that there is a suggestion, at least from this particular data, that these particular patients were in fact affected by this. What's not clear from the block study is whether there were other confounding factors that occurred later on in life that it may have affected their scores. The other particular study is the study by Bob Wilder that looked at the incidence of learning disabilities in kids under 4 years of age out of the Rochester, Minnesota area, or the Mayo Clinic area, catchment area. And what they in fact noticed was that, that in those particular patients, they were able to track both their academic performance in school as well as have the ability to contact learning centers for kids that were receiving supplemental help in terms of potential learning disabilities. What they found was a couple of interesting statistics. Number one, roughly 20% of people sitting in this audience have a learning disability. So namely, those kids who didn't have surgery, who went through life, roughly 20% of those people in that school district had a learning disability. So in the normal population, roughly 1 in 5 of you have a learning disability. So if you look to the left, look to the right, up and down, one of you sitting here has a learning disability. That's what that says. In addition, they also discovered that if you had one operation, your incidence of learning disabilities was no different than the general population. If you had one operation, you had no difference in your learning disabilities. And if you had more than one operation, your incidence of learning disabilities almost doubled. It went up to 35–40%. So that repeated exposures to anesthetics and surgeries were thought to contribute to that. Finally, there's studies that have looked at, and those are probably the two biggest studies that have shown differences in this. There are studies that have shown that there are no differences. Studies looking at twins, monozygotic twins. The Bartle study in the Netherlands has shown that, in fact, if you look at twins who are monozygotic, you have three outcomes. You have outcome number one, where both twins had anesthesia. You have outcome number two, where both twins never received an anesthetic. And you have the ideal situation, where one twin received an anesthetic and one twin did not receive an anesthetic. When you compare the groups of twins where both twins did not get an anesthetic compared to both twins who did get an anesthetic, you found that there were slight differences in terms of their educational scores in that group. However, when you compared the group that basically one twin in the family got an anesthetic compared to the other twin who didn't get an anesthetic, and they were in the same family, when you compared those twins, there were no differences between them. So what you start to see is that there may be genetic predispositions, there may be environmental influences that affect this. And lastly, there's a study also out of Denmark by Hansen looking at kids who had inguinal hernia repairs under a year of age, and what they found in those kids that are roughly at 14 years of age, there was no significant difference in their school performance. So the question is it time to change your practice? Do anesthetics make you stupid? Whoop. So, 2% of you think you've changed. Okay, good. All right. I don't know the answer to it, by the way. And so, you know, basically what we tell parents today as they come to the operating room is that there's data out there that suggests this may be a problem. There's data to support that it's not a problem. And what we basically tell parents is that if the surgery is necessary, then this is something we should be doing, and we shouldn't be thinking twice about it. So that's our sort of thing. Okay, the next topic, I guess, is mine as well. And so, is parental presence in the operating room necessary? So again, by way of show, as you answer this question, how many people here, as a part of their routine practice, take care of kids? Okay, great. Okay, so let's answer this question. So 80% don't think it's necessary, 20% think it is. Okay, so what is the data on this? Well, this is one of the more interesting telling tales. This is sort of the how do we beat our wife kind of scenario in life. And that is, you know, what we don't talk about, which is namely the negative behavioral changes that occur in kids following surgery. Roughly, somewhere on the order of about 40% of kids a couple of weeks out after surgery will have had negative behavioral changes following surgery. So the question is, what are these negative behavioral changes? There's aggressive behavior that the parents note. There's sleep disturbances, there's enuresis that occurs, there's inattentiveness in terms of school performance, there's a huge amount of separation anxiety, eating disturbances, and in parents being questioned about their child's behavior, they will comment that there have been significant changes. And these changes last from days to weeks out, and roughly about 35 to 40% of kids are affected by this. And those kids who come in with high anxiety at the time of surgery are much more likely to show these changes than those with low anxiety, and it lasts longer in those kids in high anxiety. Interestingly enough, the temperament of kids, some age tends to be more affected, not surprisingly. Kids 1 to 5 years of age are at the highest risk. Those kids who are shy and inhibited tend to have the higher risk versus the more socially adaptive children. The experience becomes important, and that is previous hospitalizations, previous encounters in the medical system, and I'm not talking about just going to the doctor's office, tend to be factors that affect this. And finally, there are parental traits. Anxious parents create anxious kids. So not at all surprising that these things may in fact occur. Other parental factors include divorce, so parents who are divorced and have a lower educational level tend to have their kids at a higher risk for this. Parents whose children are not in daycare also tend to be more susceptible. And parents who were frequent patients themselves sometimes relate their anxiety to their children in this whole scenario. What we do know is that anxious parents create anxious kids, and in a study done by Doe and Bevan a number of years ago, looking at this, what they did was in a very interesting way, in a well-designed way, they looked at this and they rated the anxiousness of the parents versus the anxiousness of the children, and what they found was that, in fact, if you were an anxious parent, your child's anxiety at the time of induction tended to be higher than if you were a parent and your kid and you weren't anxious. And if you notice on all of this, and what you'll see, I think, in the next slide, maybe, is that if you're now looking at anxious parents and you are allowed to go into the operating room, your parental anxiety level goes up if you are an anxious parent. And if you are an anxious parent and if you're not an anxious parent and you don't go into the operating room, you tend to have a level of anxiety that remains pretty low. So what in fact happens is you take parents who are anxious, you put them into the operating room, they become more anxious, and their kids become even more anxious. If you take non-anxious parents and you put them in the operating room, their kids tend to remain relatively calm. So that was sort of the model behind all of this. And what becomes very interesting is that when you start to put kids with and give them and their parents different options in terms of coming to the operating room with either parental presence or with midazolam, what you find is that parents who are given a choice and go to the operating room, and whether their kids had midazolam or not, 80% of these parents will request wanting to go back to the operating room again. 70% of parents who have had parental presence will, in fact, choose it on subsequent times again. And if you give 23% of the parents whose kids were given midazolam will request midazolam again. So roughly 1 in 4 of the parents think midazolam is a good thing. And those parents who had no intervention at all, that is, their kids did not go get midazolam, did not have parental presence, only 15% of them think that that's a particularly good idea. If you look at parental presence and pre-medication, it's not additive, so that there's no additive effect of having parents come in with a well pre-medicated kid. But what I think is interesting, and hopefully we can get the next slide. Go back. There we go. What I think is very, very interesting, and we're all faced with this now in our daily practice, and that is we're looking at outcomes based on parental and patient satisfaction. And by the way, it's coming to a hospital near you in the sense of your reimbursement will be markedly affected by how people perceive this. But what's interesting is if you look at the parental perceptions of all this, parents believe that regardless of the child's age, that 68%, almost 70% of parents believe they made the anesthesiologist's job easier. 90% of parents believed they were helpful for the child, and 98% of parents said, I would do this again. That's the parents' perception. What are the anesthesiologists' perception of this? Quite different. 21% of the anesthesiologists believed that the parents made it more difficult, 12% believed that the parents were actually helpful, and 38% believed that there was no effect from all this. So we have a total disconnect of what the world of what our professional colleagues see and what the parents see in all of this. So one of the things is, how many people here practice in a place where you, just by a show of hands, have parental presence in the operating room? In the operating room. Okay? And how many people here practice in a place where they have parental presence in the recovery room? So almost an equal number. So what we're now starting to see is that maybe the role of parents needs to be expanded. And in fact, in a paper that was published in Anesthesia Analgesia in the last, I believe it was 4 years ago, the group here out in, I believe this was in Vancouver, in British Columbia, looked at the effect of parents in the recovery room. And what they found was, in fact, that negative behavior, that ability, as I showed you that slide at the very, very beginning, negative behavior of their kids was such that parents in the recovery room markedly attenuated the incidence of negative behavior in the postoperative period. So having parents present in the recovery room, having parents present in the operating room may in fact start to reduce some of this negative behavior that we're starting to see. Nobody's really looked at the effects of parental presence on the period of time a couple of weeks out in terms of children's behavior. We've looked at it very carefully in terms of the induction process and the like, but I think we need to focus on more of the long-term outcome of all of this. My responder there, it's not working. Okay, so for those of you who vote, how many people here believe in parental presence in the operating room? Interesting. Okay. Okay. Next question. I guess this is mine as well, and then I'll relinquish my chair here. So, do anesthetics make you wild in the PACU? Emergence delirium. So most of you believe that we have an emergence delirium problem. Okay, great. Makes my job easier. So if in fact you look at recovery and anesthetic agents, you find that the incidence of excitement ranges anywhere from what's published to be 10% up to 55% of the patients, following a whole variety of different operations. And depending on whether it's the anesthetic, it's the pain, it's frequently difficult to tell what it is. Joe Crivero did this work at Dartmouth looking at kids with PE tubes, myringotomy and tubes that were premedicated, and in fact noticed that the incidence of agitation of halothane versus sevoflurane was markedly different in the halothane anesthetized patients, and it affected hospital discharge as well. And so we sort of looked at that and asked the question of whether or not myringotomy and tube might be associated with pain, and I guess I'll get back to that in a second. So his follow-up study was to sort of look at this, looking at MRI patients, and he in fact noted that there was what we considered a low threshold and a high threshold for emergence agitation. Low threshold is the kid who is sort of squirmy in his bed, just sort of making noise. The high threshold is the kid who in fact was trying to jump out of the bed, biting the nurse or whatever there. And the problem with a lot of the emergence agitation data is in fact that emergence agitation is like pornography, and that is, it's hard to define what it is, but I know it when I see it, type of thing. And so when you look at a lot of these studies, the incidence of these change because, in fact, you have different people, different set of eyes looking at this. And in fact, if you look at different anesthetic agents, what you find that is if you look at propofol versus sevoflurane in kids who were undergoing multiple eye examinations. So no pain was involved in this, eye examinations for retinoblastoma. They in fact found there was a marked difference between propofol and sevoflurane. And then finally, Jerry Lehrman and Nancy Sikich at this point in time at Toronto Sick Kids came up with what was called the pediatric emergence emergence delirium score, and in fact being very specific, very quantitative in their ability to do that. And that in fact has made a huge difference in terms of being able to compare studies from one to the other. One of the things that we did, and this was before the time of this agitation scale came up, is where we sort of addressed Joe Crivero's concern, where we looked at kids undergoing myringotomy and tube, and what we in fact found was that we divided the kids into halothane versus sevoflurane. Half of the kids got IV ketorolac, the other got IV placebo in an intravenous injection that did not involve an intravenous catheter, but just using the needle of a TB syringe and injecting the medication directly into the IV. And what we in fact noticed that if you treated some of the pain-related issues, the agitation incidence markedly diminished. So that in children treating with Toradol versus children treated with placebo, the incidence went from 40% roughly to 10 or 12 to 12 or 14%. So there's a marked attenuation in this disruptive behavior looking at pain. And this has been one of the biggest problems in all of this. And so some of the studies that have now looked at trying to preemptively look at this, and they've looked at alpha-2 agonists, propofol and physostigmine. And the data on this is very interesting. In dose-related studies looking at dexmedetomidine, and again, this is an off-label use for dexmedetomidine. In dose-related studies, Abashi noted that, in fact, at 0.3 mics per kilo being infused over roughly 10 minutes during the operation, towards the end of the operation, these kids, the incidence of emergence agitation was markedly diminished. And there was a dose-related effect to this, but at 0.3, he did not go to higher doses in all of this. I will tell you that at our institution at the Children's Hospital of Pittsburgh, we used dexmedetomidine. Again, this is an off-label use, and I'm just telling you this because this is what we do. Dexmedetomidine is used on a vast majority of patients. As a matter of fact, it's used on so many patients that, in fact, the first question asked by the PACU nurses, did this kid receive dexmedetomidine? We also administered it in an off-label use in terms of we administer this as a rapid IV bolus as opposed to a 10-minute infusion. So it can be given at the time when the kid shows signs of emergence agitation. Propofol has also been used, and in doses of 1 milligram versus saline, it's been shown to be an effective agent in reducing the incidence of agitation, both in the incidence as well as in the PAED score of these particular patients. There have been other studies looking at propofol as well, and again, the magic dose seems to be about 1 milligram per kilogram in reducing the incidence of this. Physostigmine was thought to potentially be a good drug. Other than inducing PONV, there really isn't much effect of this particular drug on emergence agitation. So, whoops. Do you think your anesthetics make your child wild in the PACU? About a little bit more. Okay.
All right.